Dr. Deepak Bhojwani is present. Please be present here.
Good morning, friends. I'm presenting a novel method to assess distance stereopsis using an inverted telescope system and a near vision chart like TNO test, and compared it with the standard of care, which is projector chart CP690 for distance stereopsis. Why do we need to measure distance stereopsis? One is, of course, for entertainment, because our distance stereopsis will decide whether we'll be able to enjoy 3D movie or not. Also, the application that the previous doctor showed can be used only if you have distance stereopsis present. So you can't use virtual reality if you don't have distance stereopsis or degraded distance stereopsis. And of course, at this point in time, we use it as pediatric ophthalmologists and squint specialists for assessment of patients who have intermittent exotropia, where it is the gold standard measurement, and for esotropia with divergence paralysis. There is enough evidence in the literature that if you miss measuring the distance stereopsis and operate the patient late, where there is complete loss of distance stereopsis, post-operatively you never get full 3D vision for distance in these patients. Currently available tests are: number one, Frisbee-Davis test, which is the most popular test, which is kept at 3-meter distance. It's a contour stereopsis test, quite expensive, 1,60,000, and provides only one plate for the checking. You have distance Randot test, which is relatively cheaper, but has high amount of false positives, and NIDEX CP690 system, which is what we have been using. The tests uniformly have technical issues also, like it measures only contour or peripheral stereopsis, and all of them have false positives because of the presence of monocular clues. Sometime back we published that you can use binoculars, as you see over here, in an inverted fashion to create a sense of distance in combination with any near vision test, such as the TNO test, which is what we use. The aim of this study was to find whether the distance stereopsis test on CP690 chart was predictive of stereopsis on inverted telescope and TNO system when used together. That is, to find whether there are any false negatives or no. And second, the effect of increasing amount of anisometropia, specifically anisomyopia, on distance stereopsis, because that is what we create in patients who are treated with monovision. We included subjects who were orthotropic and aged between 10 and 42 years and had a best corrected visual acuity of 6/6 with the binocular single vision present on Worth-Fodor test for near as well as distance. They were prospectively recruited for the assessment first with CP690. As you see over here, the subject is asked to first the subject will have to wear the optical correction if there is any spectacle or contact lenses, and on top of that they'll have to hold these Polaroids, and the CP690 will project this kind of a contour lines at a distance of 3 meters, and then you record the presence or absence of stereopsis and grade the stereopsis as 1 arc seconds, 2 arc seconds, or 4 arc seconds. And once patient says there is stereopsis, you introduce plus lenses in the steps of 0.5 diopter and induce an isomyopia until patient says either degradation of stereopsis or loss of stereopsis. And the same thing is done with TNO chart. Only thing is we would introduce a binocular in an inverted fashion. We had 10 subjects in this study aged between 10 and 42 years. 4 of these were males, and all of them essentially had high grade stereopsis for distance of 1 arc seconds on CP690. When we created anisomyopia by increasing the plus 0.5 diopter spheres incrementally put in front of the right eye, all the subjects did appreciate blurring, but there was no degradation of stereopsis until suddenly the stereopsis disappeared at 3 diopter of anisometropia on both as TNO as well as CP690. So one conclusion coming out of this study is presence of 1 arc seconds of distance stereopsis on CP690 was highly predictive of presence of stereopsis on inverted telescope system. We had no patient who had not have stereopsis on TNO chart, which is more difficult actually. So no false negatives on TNO. And 3 diopter sphere of anisomyopia is not compatible with presence of distance stereopsis, and hence one should not be creating anisomyopia or monovision for treatment of patients who are having progressive myopia in children, or in adults also you don't want to create 3 diopter of anisomyopia. The reason we chose TNO test is it's a popular test for assessment of near vision, and it produces random dot stereopsis, which has absolutely 0 false positives. If you have stereopsis on TNO test, you will have stereopsis on all other tests available in the market. You can grade the stereopsis either in radians or in arc seconds by converting using a multiplication factor, and you can find out what distance is being created when you hold your telescope in an inverted fashion using this formula U equal to 1 by V. Anisomyopia in previous studies was found to be more degrading than anisohypermetropia. That's why we used anisomyopia. Plus, it has clinical applications. And 3 diopter of blur was certainly not compatible with the distance stereopsis. So one should not be creating such kind of situations. Investigations like Dr. Dadia and Jethani in the past have shown that there is graded reduction in the near stereopsis when you create this kind of a blur. And we found this is possible to be simulated if you have had a situation where you graded the stereopsis instead of using a fixed chart. So the conclusion overall is one should be using a distance stereopsis chart, which I just showed you, which has a gradable stereopsis, and future studies are needed to find whether the inverted telescope system can be combined with other near stereo acuity charts like Randot test or word flight test to assess distance stereopsis. Thank you very much.